the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
Greetings for the day. Welcome to another PhysioTV session. Today, the topic for this session is advances in management of cerebral palsy. Today, we have with us Dr. Sandeep Patwardhan sir, who is a pediatric orthopedic surgeon, and Dr. Saloni Raje ma'am. She is a developmental and neonatal therapist. Dr. Sandeep Patwardhan sir is a well-renowned pediatric orthopedic surgeon known for his work and wisdom in the field of pediatric orthopedics. He is also a postgraduate teacher and professor at Sanchevi Institute for Orthopaedics and Rehabilitation. He has over 30 plus research publications in national and international journals and has been an author for multiple book chapters in leading publications. We welcome you, sir.
Thank you.
Dr. Saloni Raje ma'am, she has done her bachelor's from Sanchevi Institute and master's from Massachusetts General Hospital in Boston. She's an internationally certified neurodevelopmental therapist. She has over 10 years of clinical experience as a developmental and a neonatal therapist. She's currently a consulting neonatal and pediatric therapist at Dr. D.Y. Patil Medical College and Hospital, Pimpri, and a consulting pediatric therapist at KEM Hospital, Pune. She is also pursuing a certification in sensory integration and feeding and lactation counseling. We welcome you, ma'am.
Thanks.
So today we are going to take an interview for the both of you, and I'll be asking the questions. My first question is to Dr. Patwardhan sir. So as we know, most of our viewers know that Botox can be given for children with cerebral palsy. Can you tell us about the advantages and disadvantages of doing Botox repeatedly for multiple times?
Okay, thanks. So it's a pleasure to be here to talk to you about various aspects of cerebral palsy. And it's a very important question as to when to use Botox, because a lot of therapists, neurologists, as well as pediatric orthopedic surgeons sometimes misinterpret the value of Botox. And sometimes there's a lot of overuse, and we are seeing the results of a lot of overuse of Botox causing harm rather than good. So what's happening here now is that when you have a child who is in the age group between 4 to 8 and he has just started walking, and your therapy is getting stuck at a certain point where compliance is an issue or brace wear is an issue, or you want to achieve some specific targeted goal. Say you want to improve his stance phase by bringing his heel down, or if you want to reduce his scissoring because there is a lot of adductor or medial hamstring spasticity. So for focused targeted gains, Botox, when there is no contracture, which is very important, is uh, the ideal way of using this medication or drug. You all know that Botox has got a temporary effect. It lasts for about 6 months to 9 months. And with good therapy, you can potentiate it to maybe 2 years also sometimes. We have seen long gains in children who are followed up with good therapy and good bracing protocols. So, if there is a targeted functional gain which is to be anticipated in a child who has the potential to be a walker, say DMFCS 2, 3, Botox becomes a very useful adjunct provided used in the right dose in the right muscles in cases where there is dynamic spasticity, not when there is a contraction. Okay, so what happens is that people advise Botox for GMFCS 4 and 5 in children who have multiple issues with multiple contractures. In older children, where it is not going to work. So unnecessarily, the drug also gets a bad name when it is not used in the right indication, where there is no benefit to be gained. Sometimes in older children, Botox can be used for pain relief purely. So sometimes in adult CP also or neurological conditions, we can use Botox, but it is very specifically for pain relief therapy and not for any functional gains. So when you give Botox, it's good to have a dialogue with the therapist and for the therapist to refer patients when they have a war or a fight happening between the patient and the therapist regarding brace wear or compliance, which means the muscles are getting tighter as the child is getting taller. So if you use it targeted, it's a wonderful way of treating spasticity. In our practice, the cost is always an issue, which is why fortunately we haven't been able to inject more than twice or maybe thrice in rare patients. Whereas abroad, because of overuse of Botox and multiple injections, they have not documented that actually the muscle undergoes fibrosis and can become permanently damaged or weak. So frequent injections of Botox are not really recommended. And we hardly ever get those problems because our patients, one, don't come back for the second injection. They would rather get a surgery done, or they don't perceive the benefit of Botox to their expectation and they don't want to spend money on it. So overuse of Botox in our country is not a very common phenomenon. But theoretically, from the Western Australian world, we have seen that too many Botox injections can cause permanent muscle fibrosis, which is irreversible. So they have also weaned themselves off from doing too much of Botox. So that would be my perspective on this issue of Botox.
Thank you so much, sir. I'm sure you've shed an amazing light on using Botox as a treatment method for multiple times or reusing it for a period or for a long period of time. Saloni ma'am, so today our topic is advances in management of cerebral palsy. Can you tell us about the upcoming therapy strategies or newer techniques that are being researched that can be used in the management of cerebral palsy?
All right. Good morning, and thank you so much. It is always nice to be with Dr. Patwardhan, who is also my mentor and guide. So thank you for inviting me. In my case, what we, as a physiotherapist, as an opinion of a physiotherapist, what I want to say is there is so much complexity in the schools of thought for motor control and motor learning, as well as the schools of thought for the treatment approaches itself. We have so many types of treatment approaches. We have newer, kind of robotic and body weight support systems that are coming in. We have virtual reality coming in. We also have so many orthotic and adjunct therapies that are coming in. So the amount of treatment approaches that are available to a child with cerebral palsy are kind of increasing day by day. What I kind of want to say, though, it is more important to see which of these are actually working towards improvement of functional goals. So in fact, when we look at advances of treatment strategies in cerebral palsy, we want to actually see which are the ones that have now shown enough research that they are being, can be used to improve physical function in both children and young adults with cerebral palsy. So right now, recently in 2021, there's international guideline that has come in. It is by Michelle Jackman and her colleagues, and it kind of focuses on interventions to improve this physical function in children and adults with cerebral palsy, and it focuses primarily on the guideline that it should be a child-centered care, it should be a family-centered care, and that we need to look at treatment differently for neonates, for infants, for toddlers, for children, and for young adults based on their GMFCS levels, which is their gross motor function levels, as well as their MACS, which is the manual ability classification levels. So it's definitely changing, and but we're very happy that an international guideline has come into place, and it has given 13 recommendations, which deal with both good practice recommendations as well as evidence-based recommendations.
So, sir, apart from the conventional surgical approaches, what newer surgical approaches are being researched or are being developed for the management of cerebral palsy?
Okay, so to answer your question, per se, surgery in cerebral palsy is more for the walking child, which means GMFCS 3, maybe sometimes 4, and primarily aims at two things. One is we need to lengthen the soft tissues which are shortened, like contracture releases and deformity corrections. And second is we need to stabilize the bony levers and make sure that the joints are located, which means if you have a hip dislocation, it needs to be put back by a bony surgery early in life in non-walkers. And in walkers, we'll need to correct the hip and knee deformities and stabilize the foot for stance phase control in case they are developing a midfoot break or an unstable midfoot stance phase, and combine it with a supracondylar extension osteotomy and hamstring releases and rectus transfers. So we have to balance out the power as well as we need to correct the bony levers to give stability in stance and proper excursion in swing so that the child can be made to ambulate without pain, without much of deformity. Okay, so that is the purpose of surgery. So in the earlier days, what used to happen was that there was something called as birthday syndrome. That means the child used to get a surgery every year. And this all used to happen repeatedly. Whereas nowadays we believe that we should intervene as late as possible and do all the surgical procedure at one time. So up to 2 to 3 years, it's therapy and making a diagnosis. 4 to 7, 8, it's usually Botox and therapy. And 9 to 12 is some soft tissue limited surgeries. But 12 and above will be something that is called as now single event multi-level surgery. So single event multi-level surgery for final correction towards maturity has become what is new and offers the best outcomes as far as surgical results go, where we can uh, resolve all the soft tissue contractures as well as use bony procedures to stabilize the joints and correct deformities so that we don't have to repeat the surgery at an older age. So we prefer to do it towards maturity. Some people are also trying selective dorsal rhizotomy, that is a neurosurgical procedure, surgically to cut off the selective nerves which are causing spasticity, and maybe that will reduce the hypertonia, hyperreflexia, and spasticity in the lower limbs and allow for better therapy. But that cannot replace orthopedic surgery. It can be an adjunct where we will still need to correct the bony deformities and contractures in addition to control of spasticity with the neurosurgical procedure. So that is something new that is being tried in select centers with the help of neurosurgical colleagues. A word of caution here is I always like to tell that stem cell is not really an approved or an effective therapy for CP, though it is being marketed as such in certain quarters in our country. But we don't have adequate data, or it's more or less an experimental kind of therapy which is being done using stem cells at exorbitant cost. Ideally speaking, ICMR has only recommended that stem cell be used in approved centers free of cost on an experimental basis, whereas it should not be offered to patients, unfortunately, as a therapeutic or a curative surgical intervention, because it really doesn't work. We have seen disasters coming back to us having spent a lot of money with really no outcomes. So a word of caution about that, which is not proven and experimental.
Thank you so much, sir. So Saloni ma'am, since you are a pediatric therapist as well as a neonatal therapist, can you shed some light as to when do you think a physiotherapist can intervene in managing a high-risk infant?
So I always say nothing is too early. Physiotherapists have now kind of, gone through the spectrum of care. So you start seeing the child in the neonatal unit itself, in the NICU. And so you see him on the first day of life. And you continue to see him as this child with cerebral palsy continues to be a young adult. So one of the things about, physiotherapy or any kind of rehabilitation care, whether it is occupational therapy or speech or language pathology, I think if we are fortunate to see the child on the first day of life, we should start physical therapy interventions at that time. Obviously, therapy is different at different stages of life. This is very, very important for us to understand. On the first day of life or the first week of life, as this high-risk neonate is being supported by the neonatal care unit to, be medically stable, to be healthy, whether at that time, as a therapist, we are providing what is called as developmentally supportive care. So we are helping with early developmental positioning or developmentally supported positioning. We are helping with sleep regulation, with light and sound modulation and management. We are there to provide oromotor interventions after 30 weeks of gestation. We are there to kind of work with lactation consultants to help with early latch, non-nutritive sucking. And just we progress on to early tummy time, early prone behaviors, early upper extremity, grasp and reach at 1 or 2 months of, around 2 months of life. We are trying to get visual tracking early. We are trying to see whether this child will look at his rattle, will, track the sound of the rattle, and so on and so forth. So, and obviously we're going to move on to, development of head control, development of sitting balance, learning to sit, learning to stand, learning to walk. But at the end of the day, I think nothing is too early. If we can create developmentally supportive care right from the first day of life, we can really kind of, improve quality of care of this individual and also get the family involved in the care, improve just, more family-centric care. I always say the earlier we intervene, we are able to provide more family-centric care, because we don't know whether this child of cerebral palsy is going to become a grade 1 GMFCS level, who's going to walk without support. He's going to be a grade 2 child who will walk with some difficulty, a grade 3 which will walk with a walker, a grade 4 who may not be able to walk for at all or may need powered mobility, so will require some upper extremity control, and grade 5 who will be completely dependent, will require a lot of adaptive assistance for seating. So as we know that this is an evolving lifespan condition, it's not that you have CP or you don't have CP. You will have CP all your life. Right. So managing the impairments, whether they are primary or secondary musculoskeletal impairments over time, is an important role for a therapist. So nothing is too early. Day 1 is where we would like to intervene.
Yes. So you said that the clinical guidelines in 2021 that have been published. So they focus more on family-centric and child-centric approach. Can you tell us what exactly the role is of friends or family, which will help in the improvement of the outcomes of a cerebral palsy child?
Sure. So we know now the F words of cerebral palsy. This is directed to me or sir? I'm
Yes,
so sorry.
to you, ma'am.
To me still. All right. We know that now we have the F words of cerebral palsy, right? We have function, family, fitness, future, and friends, So we have the F words of cerebral palsy, all of which are looking at this child's quality of life and his ability to, socialize with his community. So it is very important to understand that sometimes we have a tendency to do therapist-oriented goals, what we think is right for the child. A lot of times we say, oh, no, do this, only we should do this. Y'all don't do this at home, right? But we know that one is early neuroplasticity, means that the child, needs a lot of repetition when the brain is changing in order to achieve a lot of these functional outcomes. When we look at very, very young children, when we look at children as young as, say, 1 month of age, at that time, we are looking at a lot of kind of care which is based in the comfort of the family, a lot of kangaroo mother care, a lot of early feeding, early oromotor work, early tummy time. And so we need to understand that the family plays a huge role, whether this child is at 2 months where it requires a lot of kangaroo mother care and a lot of feeding and a lot of this, or this is a child at, 8 months or 1 year that we are teaching to sit. We want this child to learn to sit not just on the floor, but maybe on a feeding chair, because it's easier for the mother to, feed him in sitting with a feeding chair as opposed to practicing only floor sitting. So giving these various variations, in goal settings, which are more family friendly. So you always ask the parent what they want. And I'll be the first person to say that parents can have unrealistic goals, and a lot of times they want walking at 12 months when this child is not even sitting.
Yeah.
But if we as therapists and obviously our collaborative colleagues on, the pediatric orthopedic side, pediatric neurologist side, all of us can, have a conversation about whether any of these goals are realistic as of today, right?
Yes.
Or not. These are few conversations that we need to have, smart-based goals. We need to have them specific. They need to be measurable. They need to be accurate for that or appropriate for that age group. And they also need to be realistic, because sometimes you cannot get walking in a child with GMFCS 4 or 5.
Right.
And so if it's an unrealistic goal, even though we want it to be family centric, but we also want to be able to be very impractical and very passionate guides to these families, saying that we want to make goals that are more family friendly, that are more child centric, are chosen by the child themselves, because this will motivate the parents to also work with them. So there's a child with hemiplegia who wanted to play cricket, in my experience, and instead of doing the hand, you just constraint induced movement therapy, bimanual therapy, playing cricket helped him much more. Everyone was involved. The father was willing to take this child to the playground every day to play with him, to play cricket with him. And we got a lot more hand function with that goal, instead of putting a goal like, okay, let's put 10 pegs in this amount of time.
Right.
So I'm always a big proponent of family-centric goals. Thank you.
Thank you, ma'am. Thank you, sir, for your esteemed opinion. The other part of this interview will be published soon, so stay tuned. Thank you.